Good afternoon. We will continue with the lecture on dental trauma. So we have completed crown fracture, uncomplicated crown fracture, and we have discussed about the management of uncomplicated crown fracture. Now we will move on to complicated crown fracture or fracture with pulp exposure. The definition goes like this: an enamel dental fracture with pulp exposure. Diagnosis: clinical and radiographic findings reveal a loss of tooth structure with pulp exposure. Clinically, when you see there is a fracture, a piece of the tooth is gone, and radiographically also it is visible. Plus, there is pulp exposure. Treatment objective is to maintain pulp vitality and restore normal aesthetics and function. It is not that easily said. It is easily said than done, because the patient has to report to you immediately for you to maintain pulp vitality. If the patient reports to you immediately, you will cap the pulp and restore the normal aesthetics and function. Whereas if the patient reports to you much later, you might have to do the endodontic management of the tooth. Injured lips, tongue, and gingiva should be examined for tooth fragments, like in uncomplicated crown fracture, because we don't want this to get embedded in the soft tissue. This is a case which was done in the department where the patient's anterior tooth, fractured anterior tooth, was restored immediately, and the patient had to undergo endodontic management. If you see, the incisor ledge is kept a little lower than the other adjacent tooth or the other central incisor, basically to prevent the tooth from coming into occlusion. Primary teeth. Decisions are often based on the life expectancy of the traumatized primary tooth. If it is nearing exfoliation and root resorption is almost complete and the permanent tooth underneath is about to erupt, we don't think about trying to save the tooth. And vitality of the pulp tissue. Many times the patient don't report to you immediately and the tooth goes into necrosis. And if there is a peri-apical lesion which is jeopardizing the health of the underlying tooth bed, it is better to extract the tooth. Pulp treatment alternatives, if the patient reports to you immediately, are pulpotomy, pulpectomy, or extraction. Pulpotomy, if the tooth is vital and patient reports to you immediately, you can cap the pulp and you can give a restoration. Pulpectomy or extraction, if the tooth is non-vital. If tooth cannot be saved, you think about extraction. Permanent teeth, pulp treatment alternatives are pulp capping, pulpotomy, and initiation of an RCT. That is, if the patient reports to you immediately after trauma and the pulp is exposed, you cap the pulp with a material like hard-sitting calcium hydroxide or bioidentine, and then restore the tooth with a restorative material. If the inflamed pulp has, the exposed pulp has been inflamed at some area, you can amputate the inflamed area, initiate fresh bleeding, control the bleed, cap the pulp, and then do a restoration, which is called the pulpotomy and restoration. Or sometimes if the tooth is non-vital, you can think about initiating an RCT, removing all the pulp tissue. General prognosis. A concomitant injury to the periodontal ligament, that is, if it is associated with the luxation injury, then the prognosis is guarded. Age of the pulp exposure. If the patient reports to you immediately after trauma, then the prognosis is good. And extent of dentin exposed. If there is considerable amount of dentin exposure and loss of tooth structure, restoration becomes a little difficult. Might have to crown the tooth. Stage of root development at the time of injury. This is what I keep telling. If there is exposure that has happened, if there is an exposure that has happened, and the patient reports to you immediately after trauma, and the root formation is not complete, that is, the tooth has blunderbuss canals or the neovascular bundle is quite thick, then the chances of tooth going into non-vitality is less. But if tooth with open apex is exposed and the patient does not come to you immediately after trauma and the pulp gets infected, then the prognosis is guarded, because the root formation is not complete and you will have to either go for an apexogenesis or revascularization of the tooth. Optimal results, treatment results, if immediate assessment and care is given. That is, if the patient reports to you immediately and you take care of it immediately after trauma, the prognosis is very good. Complicated crown fracture in a tooth with open apex. This is what we were discussing just now. If the tooth is immature As you can see, the apex will be open, and in case of an open apex, the neurovascular bundle is quite thick, and the chances that it severs off at the apex is quite less. But when there is a pulp exposure, it has to be immediately capped and completely restored so that the pulp does not get exposed to the oral environment. And it has got very thin walls if you see the apex. So when you instrument it, it might be a little difficult. Whereas in closed apex, you have thick walls. But see the thickness of the neurovascular bundle, it is quite thin. So the chances that it severs off at the apex and the tooth goes non-vital is pretty high with teeth that have completed their root closure. In case of an immature tooth with non-vital pulp, you might have to go for an apexification. You will remove the complete pulp tissue completely and place a material that can initiate some amount of calcification at the apex so that you get a calcific barrier to complete your obturation. The procedure is called apexification. We will go into the details of it in your pulp therapy classes. Crown root fracture. Definition is enamel, dentine, and cemented fracture with complicated or without, that is called the complicated one, or without pulp exposure, that is uncomplicated. So it can be crown root fracture with pulp exposure, which is called the complicated crown root fracture, and uncomplicated crown root fracture when there is no pulp exposure. Diagnosis is clinical findings usually reveal a mobile coronal fragment attached to the gingiva with or without pulp exposure. That is, the coronal fragment can be mobile and it can be a root fracture. Sometimes if the tooth is mobile, you think that there is luxation injury, but it might be a root fracture. So always be guarded. Make an X-ray before you decide whether it's a root fracture or a luxation injury. So clinical field findings reveal a mobile coronal fragment attached to the gingiva with or without pulp exposure. Radiographic findings. Radiographs reveal a radiolucent oblique line that comprises the crown and root in a vertical direction in primary teeth. In permanent teeth, it is usually in a direction perpendicular to the central radiographic field. While radiographic demonstration is often difficult, root fractures can only be diagnosed radiographically. Treatment objectives. Primary teeth is to maintain the pulp vitality and restore normal aesthetics and function, like I always say. When the primary tooth cannot be restored, the entire tooth should be removed, unless retrieval of apical fragments may result in damage to the subcutaneous tooth. That is, if the root fracture is at a higher level, more apically, where the removal of the fragment might damage the permanent tooth, you can leave it there and warn your patient that there is a small piece of root left inside, which is not going to cause any problems normally, but if there is a symptom, they have to report back. Usually, it will come out when the permanent tooth erupts. It will just extrude out. You don't need to worry too much about it. Treatment objectives. The emergency treatment objective is to stabilize the coronal fragment. That is, if there is a root fracture, immediately you have to stabilize the coronal fragment and make sure that the root heals. The definitive treatment alternatives are to remove the coronal fragment, followed by, if the fracture has occurred, the root fracture has occurred comparatively more close to the gingival area or more towards the cervix of the tooth, then it is better to remove the coronal fragment, followed by a supragingival restoration or if necessary, gingivectomy to increase the crown length, osteotomy, or orthodontic extrusion to prepare for restoration. If the pulp is exposed, treatment alternatives are pulp capping, pulpotomy, and root canal treatment. You can see that in this case, the fracture has occurred considerably low, so the coronal fragment cannot be. Here, the healing will be compromised. If the fracture was at a higher level, healing of root fracture usually is got good prognosis. And if you stabilize the tooth, it will heal automatically. And in long-term studies, if you check Anderson, you can see Anderson's atlas. You can see many cases where the root healing has happened. Here, if you see the fracture has occurred comparatively at a lower level, here you remove the coronal fragment, do an endodontic treatment, do a Boston core, and give a crown. Here, the osteotomy will give you more access to the fragment that is remaining. So alveolar process, which is extending, can be trimmed off a little bit. Gingivectomy can be done, and if needed, the tooth can be extruded out a little bit orthodontically, and Boston core can be given and a crown can be given based on where the fracture has occurred. General prognosis, although the treatment of crown root fractures can be complex and laborious, most fracture treatment can be safe. Fractures extending significantly below the gingival margin may not be restored. So keep that in mind. Definition: a root fracture, just a root fracture. We're talking about a crown root fracture, which is root fracture is very similar. Here there's no crown fracture, only the root fracture, and the prognosis is much better. So crown root fracture, like I told you, can be complicated and uncomplicated. Here that problem is not there because there's no crown fracture. Diagnosis: clinical findings reveal a mobile coronal fragment attached to the gingiva that may be displaced. Radiographic findings may reveal one or more radiolucent lines that separate the tooth fragments in horizontal fractures. Usually horizontal fractures, like I said earlier, occurs in a permanent tooth, but can happen in a primary tooth as well. Multiple radiographic exposures at different angulations may be required for diagnosis. Here the picture that I've shown is a horizontal fracture in a primary tooth, but oblique fractures also can occur in primary tooth. A root fracture in a primary tooth may be obscured by a succedaneous tooth. That is a permanent tooth that is developing. So you might need to change your angulations and make multiple radiographs to diagnose the root fractures properly. What is the treatment objective? It's to reposition as soon as possible and stabilize the coronal fragment in its anatomically correct position to optimize healing of the peroneal ligament and the neurovascular supply. Maintain aesthetics and good functional integrity. In case of primary teeth, the treatment alternatives include extraction of coronal fragment without insisting on removing the apical fragment or observation. In case of permanent tooth, you should reposition and stabilize the coronal fragment. This is when the patient reports to you immediately after trauma. Otherwise, it is a guarded prognosis. You have to always tell the patient that. General prognosis: pulp necrosis in root fracture teeth is about 25% is attributed to the displacement of coronal fragment and root development. The root development is happening, and it is, like I said to you earlier, it has got very thin walls when the apex is open. So then the prognosis can be guarded. In permanent teeth, the location of the root fracture has not been shown to affect pulp survival after injury. Yes. In case of permanent tooth, wherever the fracture is, the pulp survival will not affect the injury if taken care of immediately. Therefore, root fractures occurring in either the tooth cervical third or apical third could be treated successfully by stabilization of the reposition fragment and splint. You can either go for a composite splint, wire and composite splint. You can adapt the wire according to the contour of the teeth and fix it up there with a bit of composite resin. Or you can use a fiber splint to stabilize the teeth in its correct position. Before going into luxation injury, we will stop the class. Luxation injuries will be discussed in a class, further class. Thank you.